Okay, all right, we are live, and now this is still January 15th, and we're still the Senate Health and Welfare Committee. We're hearing from the Green Mountain Care Board just to give us kind of an overview of who you are and what's going on, and then we've been through a lot of bills this morning that include the Green Mountain Care Board, so we'll see where that goes. But we have lots of interest. Welcome.
So for the record, I'm Emily Brown. I'm the Executive Director of the Green Mountain Care Board.
My name is Owen Foster. I'm the Chair of the Green Mountain Care Board since fall of 2022.
Owen and I are going to be working together on the slides presenting this morning. So we have Kristen running the slides. Kristen, if you could go to slide 3 or 4. Yeah, there we go. So this is just a high level slide of who we are. So the Green Mountain Care Board was established in 2011. It's a 5-member board, independent. Each board member has 6-year staggered terms. As I said, it's independent. So we are not under the administration, we're independent. The chair is appointed and the members are appointed by the governor, but those are, again, once they're appointed, they're independent from the decisions.
And there's a nominating process.
There's a nominating process, correct? Yeah. And here are some pictures of the board members. And also wanted to mention that we are quasi judicial.
I got to add is the board members have different backgrounds. So some of us, I'm an attorney. Let's make sure I don't miss it. Jessica Holmes is an economist and health econ policy expert at Woodbury College, where she's a tenured professor. David Merman is a physician and doctor. He practices at CVMC in the emergency room. Tom Walsh is a physical therapist and also a health policy expert and professor. And Sarah Teachout is formerly in Blue Cross Blue Shield. So we have pretty good diversity of perspectives and experience that lawyer, a health economist, doctor, therapist, somebody from the insurance company. I feel like the board is pretty well structured right now in terms of different perspectives and understandings of the health system.
Next slide outlines the board's mission. So the mission is to drive system-wide improvements in access, affordability, and quality of healthcare. So what that means is that when the board is engaging in our regulatory activities, these are the principles that the board has in mind in making its decisions. So the board regulates major areas of Vermont's healthcare system, which we'll go over in the next slide, serves as a transparent source of information and analysis on health system performance. We have a data team at the board, which oversees VUDs and runs VUDs, as well as eCures, which are 2 data repositories. We also advance innovation in healthcare payment and delivery. We have a director of policy and a policy team who helps the legislature, the board, make decisions that are based on data and policy, healthcare policy. The next slide is a visual of the Green Mountain Care Board scope of regulation. So you'll see in the blue circle, there are a lot of actors and health insurance plans that the board does not have regulatory authority over. I like to mention that the board does not oversee Medicare and Medicaid. I think that's a frequent question. Medicare is regulated at the federal level, and Medicaid is a federal and state-run program. Medicare Advantage plans also do not fall under the board's purview. Those are regulated at the federal level, as well as self-insured plans. So many employers purchase self-insured health insurance plans. So those are not regulated by the board, and also out-of-state plans. On the other side, you see a list of providers that do not fall under the board's regulatory purview: federally qualified health centers, independent providers, ambulatory surgical centers, urgent care centers, and out-of-state providers. The board does regulate health insurer rate reviews. So for those plans sold on the exchange in Vermont, the board reviews those rates. We also review certificate of need. So for providers wanting to open up new facilities in the state, the board reviews those applications. And very importantly, the board reviews hospital budgets. And also at the end here, we have ACO oversight and certification. Any questions before we move on there? I know there's some new members, so I want to make sure if there are any questions about our oversight.
I'll test this question. If you have a group of physicians, practice that is part of the hospital, do you regulate that as well within the budget?
Yes, if the physicians are associated with the hospital, they work for the hospital, their revenue would be included in the hospital's budget, and we would regulate that. The way we would do that is the hospital comes in with its total revenue, how much money it plans to bring in for the year, and we review whether the charges are appropriate and how much money they're going to charge insurance companies, how much money they're going to bring in. So the facility fees that are associated with doctor visits, so when a patient goes to a hospital, they have what's called a facility fee, which is a charge for using the hospital facility. And then there's a professional fee, which is the fee for the doctor and the physician. If the doctors are part of the hospital, they would have both charges and that would come to us. If the physician group is not part of the hospital, but performs services in the hospitals, think of an outsourced group of doctors. Even think like a car garage. You have like mechanics that come in but don't work there. They take the money. In that kind of situation, that money associated with those patients would not be part of our budget review. This slide is important because I think there was a lot of misunderstanding as to what our care board does and doesn't do and what we can and cannot fix or work on. So Medicare Advantage left Vermont last year. The care board has no authority. There's nothing we can do. We'll get a lot of letters saying do something. And there's nothing.
We got a lot of letters.
Yeah. Relatedly, if you think about Blue Cross and Blue Cross's financial solvency, looks like you two drew the short stick this year on committee assignments. We got healthcare. No offense, Chair. But it's a meaty topic, so I'll try and make sure I explain it as well as possible. Blue Cross Blue Shield has around 300,000 members, I think, in its entire portfolio. What the care board regulates is about 70,000, maybe less than 50 to 60,000 of those lives. So the huge swath of Blue Cross's business that we have nothing to do with. You'll often hear a narrative or words like, well, the care board needs to give us more rate. Well, even if we gave more rate to Blue Cross to help their solvency problem, it would come out of constituents' pockets. And with the highest healthcare costs in the country, that's very difficult to do. Second, even if we did it for the QHP plans, there's 200,000 plus other lives that we have nothing to do with. So it's just important to kind of remember where we act and when we don't act. Rural hospitals across the country for the last 2 decades have really struggled financially. It is a business model that, as the health system has evolved, is not a very successful one. We're seeing closures and service line closures, hospitals going bankrupt across the country. There was one in Maine last year. There's been a number of service line closures here in Vermont in recent years. And it's a trend that's accelerating and continuing as the dollars to support healthcare and hospitals are being depleted. And Vermont is particularly at risk and vulnerable for a number of reasons. One, we have 14 hospitals in a state with 650,000 people, so there's rurality challenges. We have challenges with hospitals being able to recruit to rural places. We have challenges with the facilities being old and dated, meaning a lot of money. And there's not enough money to continue to pay for exactly what we have. The legislature and the governor and the care board recognized this in 2022 when they passed Act 167, which was about what does the system look like and how much money do we have? How short are we? That report was released in September of 2024 and found that the status quo, how our hospital system, just the hospital system, not the rest of it, currently operates, we're about $2.4 billion short of revenue to maintain the status quo over the next 5 years. Fast forward, since that report, a number of federal changes have happened, which likely makes that $2.4 billion number look rosy. So we are in an environment where we will be losing services. That is not necessarily a bad thing. There are services that we can consolidate and regionalize and make it more efficient and more affordable. There are other services that we can perform outside of hospitals in a much more cost-effective manner. And if we're able to do that, the hospital might lose the service, but the community keeps it and it's more affordable. The challenge is making that pie all fit and doing it in a very tough financial environment. This is a graph of Vermont's health insurance costs on the qualified health plan market. That's the market that we regulate as compared to national. So the yellow is Vermont and the orange is the rest of the country. And there's a couple different plans. There's different options, bronze, silver, platinum. And that's what these various lines represent. But if you look at it, you can really see since 2018, the rest of the nation has been essentially flat, really flat. And then Vermont was in the ballpark in 2018 and 2019, and ever since has just exploded. And we have become the highest, most expensive commercial insurance on the QHP plans in the country. If we don't give the insurance company enough money, they have solvency risks. If the insurance companies don't get more money, the hospitals have solvency risks. But we can't give them more money because as people pay more and more, they just drop insurance. So it actually doesn't even work at this point. And it's really bad for demographic growth, really bad for younger families who can't afford it. It's very inequitable and it's horrible for economic growth in our rural communities. I am proud that this last year, the Care Board's decision on rates was really small. The rate increases were quite low. In the nation, including the District of Columbia, Vermont had the 50th lowest insurance premium increases in the country out of 51 states in the District of Columbia.
I bet Hawaii was last.
I thought DC was Hawaii.
I don't know. I'm trying to remember.
Maybe you're right. Anyway,
But they have special dispensation.
That's a quick question, and I feel like I should know this, but per capita, how do we compare to other states in terms of the number of hospitals we have? Do you know?
I don't know that off the top of my head. I wouldn't say that necessarily, just anecdotally from my awareness of the New England market. I don't think that per capita we're an outlier in how many hospitals, but I haven't done a thorough review. I'd be guessing how many Maine has in New Hampshire. They definitely are more, not by significant amount of the populations.
I know in my time here, we've added mandatory coverage for services. I get concerned when I hear the Maine costs have as much as we do with a similar demographic. And I'm just wondering, do we look at what's required to be covered under our plans as opposed to other states?
That is an option for improving affordability. I don't believe the things that you're alluding to happened in the time frame that we're looking at in this slide. So they were already in there in the base, I believe, like some of the dental coverage and the other coverage. So it doesn't explain the growth, but yes, that would be a strategy to lower our costs. I think the question about how many hospitals per capita is a good one. And it goes to this slide here, which is how are we allocating our money? This is really a prioritization question of how we spend our healthcare dollars and where. Vermont is a huge outlier in the nation in spending on hospital care. Hospital care is the most expensive care in healthcare. And as you spend more and more, you provide more and more of your care in a hospital setting, it gets more and more expensive. Part of the transformation that we've been trying to do as a state for the last several years is to transition care out of hospitals. And I can give you a couple of basic examples. ED rooms in Vermont have patients going in with coughs, with colds, with strep throat, with tick bites. When you go to an ED for a tick bite, it's extremely expensive to the insurance company. Vermont has, I believe, only 2 ambulatory surgical centers. They often cost here in Vermont a fraction of what a hospital costs, a third, maybe half as much money. We don't have very many here, and so all that care is being done in hospital settings at really, really high prices. There's an article in 7 Days yesterday comparing costs at UVM for colonoscopies or MRIs compared to the Green Mountain Surgery Center or open MRI, and they're a fraction. So without much access to that type of service, it increases expenses. When we did the all-payer model, and Senator Lyons could speak to this, for years we've been talking about let's lower the spending in hospitals and try and transition care. It's been a theory of all of our healthcare reform for at least a decade. But what's actually happened, if you look at this graph, sorry, next slide. This is data from 2018 in the green and 2022 in the blue. And you can see that the biggest growth in our spending in the state is actually in hospitals. And that's during a period of time when the goal was to transition care to more affordable places outside of hospitals. But we haven't been effective. And what we have now is a strategy of providing all this care. Consolidating hospitals will continue to cause extreme affordability and solvency risks as we can't afford to keep going.
Yeah, the hard part is delineating which care must be moved and then having it moved.
Correct.
It's not always gonna happen. And it's a habit that actually patients get into as well, right?
It's also, it's not a light switch.
No, it's not.
Can't open up a new surgery center overnight and can't, it's challenging. Part of the issue too, and I think that the 7 Days article spoke to this, is a lot of the hospitals own primary care. And so when you get the referral from your primary care, they're going to refer to their hospital. So it's a closed loop referral system that stays in that expensive place. The independent primary care, the FQHC, is more likely to utilize some of those other services. I think you have a bill this year discussing.
Well, we just went through it this morning.
Yeah, great.
And what you just said suggests to me something we can add in.
It's just something, just something to be cognizant about.
Yeah, no, to be more specific
Yeah.
about what needs to happen.
But as we do these things, if we transition care out of hospitals, we have to recognize that it's going to hurt the hospital's finances and they're going to have to look different. If you move the care, they don't have the revenue, right? They're not getting $6,000 per colonoscopy, and that will hurt their stability as the state goes. We have choices to make, and they're hard choices. We want to go through the next 2 slides, Kristen. Some of the recent legislative action that was taken last year and in recent years, and walk through what's happened ever after, and I'll turn it down.
So we've been very busy at the Green Mountain Care Board as well as the legislature. This slide is an example of some of the legislation that was passed last year, which impacts the Green Mountain Care Board. Act 68 implemented a reference-based pricing framework, expanded data requirements, as well as improved clarity on the notice of service reduction submissions. These all impact the Green Mountain Care Board work, and we're currently in the process of implementing all of these processes. Act 55 was a major factor in hospital budget review this session or this last summer, as well as rate review. It capped the amount that hospitals could charge for outpatient office administered prescription drugs at 120% of ASP. It requires hospitals to report 340B drug acquisition and payment data. That is now live on our website and can be accessed currently. And it also requires hospitals to disclose how they use the 340B revenue to support community benefit programs. And I know a lot of these terms are in a way terms of art, so we'd be happy to come back in and talk about what all of these reporting requirements and as well as the cap do. Act 62 clarified and updated Green Mountain Care Board's regulatory roles. Act 49 protected insurer solvency by giving Green Mountain Care Board to adjust rates in the case of an insurer's solvency falling below a certain level. It established hospital observer authority under the Green Mountain Care Board, and it enhanced transparency of reimbursement structures. Act 15 required updates to the certificate of need threshold. So we are currently in the process of updating our regulation, our rule to come into compliance with this legislative change. And what those changes also did is streamline the review for smaller CON, certificate of need projects, to allow them to go through without review. And it maintained oversight for major health system investment. Anything you'd like to?
Sure.
Oh, I'm sorry.
So we just went, 2 questions I'm gonna ask. I'm gonna ask the bottom first, the second one first. You don't know that. No, but the notice of service reduction, we just went through the bill that we have in here that talks about reporting to you and AHS, and then whose responsibility it is for making a recommendation on service reduction. It'll be important for us to understand how and why. I think that was something you were interested in having happen, and why it would go to AHS and why it wouldn't be Green Mountain Care Board, and how that fits together. We continue to try to get a grasp on who's responsible for what, because there's so much going on, and I appreciate the the chaos that exists from time to time, between AHS and Humanitarian Care Board and that world. So just to let you know, we did look at it. It will be great to have you come back in to talk about that bill as well as others. And then the reference-based pricing piece, Jen went through a little bit about what it is, but we'll also, would be great to have you come in and talk about where you are with that.
Sure. I believe we plan,
There was a sort of question in there. Can you come back?
yes, we will come back. We would be happy to. The next slide actually speaks to, it's an implementation update on our reference-based pricing. So for those who are new to the committee, reference-based pricing is a cost containment strategy, which would set a maximum price for hospital services. And that price would be tied to a Medicare benchmark. We're currently engaging with stakeholders, our board members, our staff, to develop the policy for that program. And the first step being approaching rulemaking this summer in FY27. We plan to have the rule implemented by FY28 and effective, which would then start impacting hospital prices. Again, we'd be happy to come back and talk to you. And we also have a report due to the legislature on reference-based pricing and implementation in February. The next slide is a high level, again, overview of where we are with some of the legislative changes that I went over in the prior slide. We have an interim notice of service reduction policy. This is in response to the legislation that outlines what hospitals required to submit to us prior to eliminating a service. We did have one application submitted to us in December, which was the Rutland Regional Medical Center pediatric inpatient changes. They have withdrawn that reduction, that notice of service reduction, and now I believe they're working with AHS on a solution to that issue. We are engaging in rulemaking for our ACOs. Prior to this, we had one accountable care organization operating in the state, which the Green Mountain Care Board oversaw. That ACO is, I believe, ceasing operation effective January 1, 2026, or at the end of the last year. We're moving to a certification process for all ACOs operating in the state. We had a board meeting on Wednesday where we went over that rule, and it's expected to be adopted by the board, and we're moving into the LCAR process next. We issued the
LCAR being Legislative Committee on
Yes, sorry.
Administrative Rules.
a lot of acronyms.
Sorry, we haven't talked
No,
about
thank
that
you.
level of
Yes.
things yet, but we
Thank
will.
you. Appreciate that. Act 134 was our report on prescription drug affordability. We submitted that last week. That addressed some suggestions on how to control prescription drug costs in our state. One of those actually being the Array RX program, which I believe is contained in the bill that the Treasurer P-Check is now working for. We issued reporting guidance for Act 55 on the 340B reporting. And we've implemented the 120% ASP cap that was in Act 55 through our budget hearing process as well as our rate review process. Ongoing projects, which are annual part of our regulatory cycle, are the hospital budget guidance development. We're currently undergoing that, which is expected to be finalized at the end of or in March 2026. And we have worked with AHS on a Rural Health Transformation Fund grant project, which would enhance our IT systems at the Green Mountain Care Board and hopefully enable us to do more with the healthcare systems data and provide more real-time results on any impacts to our healthcare system.
Out of curiosity, will you be linking in with Vital in this? Or what entities will be connected with that project?
I don't have an answer for
Okay.
you on that. I can get back to you. I know Wendy Geller, who's our director of data at the Green Mountain Care Board, would be happy to come in. I believe she's going to be in-house healthcare soon to talk about that project and what it entails. So we would be happy to have her in here. And,
We'll do that.
okay.
We'll do that.
And I can get this specific question on Vital answered for you.
Well, it's Vital. Let's speak everything.
I know it will interact with ZCures because that
I know.
falls
Be
under the
curious
board
to
and
be there, right?
I'm not sure on that.
Well, how micro do you get? Do you get down into clinical data? Or is it all claims database? What is it? So it would be good to have that.
Sure. I'll go over our hospital budget review process. So all this work we're talking about, I would, in a hierarchy of what's the most important work, the most relevant work that we do, it's really number one, hospital budgets. Number two, that qualified health plan insurance rate review, we decide the rates. And then three, everything else, I would say, kind of goes into this conformative policy world. So hospital budget review, just to give you an overview of the process. Right now, we're currently working on guidance for fiscal year 27. And what guidance is, it tells hospitals, here's where the care board would like to see you come in and sets an expectation for how much growth we think is appropriate. It'll say, one, how much total dollars you can bring in, and then two, how much more you can charge insurance companies. Hospitals have inflation, they have costs, and sometimes they need more money. Actually, they always need more money. That has a trickle-down effect on the insurance rates. Those go up higher, the insurance rates go up higher. It's not a direct linkage. Hospital budgets are actually only a fraction of what goes into an insurance rate. There's all these other things, including the prescription drugs that people take, how often people go to doctors, which doctors they choose to go to, hospitals that patients go to in other states. There's a whole bunch of things that go into the rate. Also, the reserves at the insurance company. The insurance company has really low reserves. They need more money or they're at risk of insolvency. We just really experienced that with Blue Cross. Think of it as like a bank account. A reserve is really just, they have to pay claims every single month, maybe weekly, I'm not sure the cadence. And if the claims are higher than they had anticipated, it eats into their savings account and that savings account goes down. What we saw with Blue Cross in the last couple of years is those claims were way higher than they had anticipated and their reserves just frankly plummeted. What happens then is they come before the care board and say, look how low our reserves are. Let us increase rates 7% just to build back up our reserves the next few years. That means before we even say hello to what's going on and everything else, the rate is up 7%. That QHP just went up 7% just for their reserves. And that's really problematic because our ability to lower things gets very, very difficult and constrained. Last year, how we achieved those really low rates for Vermonters was, in my mind, really a one-time event because we looked at mostly the University of Vermont Health Network and Medical Center, and we found that they had enormous reserves and their prices were really high. And they had been doing some operational things with some other hospitals in New York that we thought was inappropriate. We essentially used a lot of that money that the network had to keep rates lower. We lowered UVM's rates by quite a bit, and that allowed us to lower the insurance rates. How often you can do that is limited, right? It's limited. UVM could do it that year. Can they do it this year? I don't know. Can they do it next year? I don't know. But there's a limit to how much you can do that. And the other hospitals in Vermont don't have high reserves either, as we'll get into. That concerns me for this coming year when we get rates that they're going to be quite high. And with the hospital system largely also facing insolvency risks, there's really nowhere to go other than the system needs to change rather dramatically pretty quickly. So the guidance goes out, we finalize it March 31st. Hospital budgets are submitted to us on July 1. They're large, I mean, the binders are huge. It's a lot of complex data. We have an outstanding staff that pours over this for a couple of months. And by September 15th, the 5 board members need to vote on each hospital's budget and say yes or no. And if not yes or no, what is it? And generally we're deciding again, how much revenue. A lot of times now we're saying, look, you've had all the rate increases over the last 10 years. You have some of the highest prices in the country at some of these hospitals. We can't give you more rate. We already got it. So you're going to need to do something different. Or we look at that total revenue and say, okay, some of this care can be moved elsewhere. You need to find a strategy to move this care out of your hospital to other places. Some situations that's easy, some it's difficult. I'll spend just, Caroline, do we have till noon or how long would you like us to?
Yeah.
We have until 12 o'clock.
Okay, we'll speed it up.
Got it.
This is an important point. Our hospitals are in financial distress, and I'll explain which ones and to what degree. On the right is a chart of Standard & Poor's methodology for evaluating hospital system health. And this is days cash on hand. That's how much money they have in their bank that allows them to operate if they brought in no more revenue. The rating agencies consider anything under 110 to be either vulnerable or highly vulnerable. And over here is a chart of the days cash on hand in fiscal year 26 budgets. So as you can see, Brattleboro with 72 days cash on hand is highly vulnerable. If you go to Springfield, 33 days cash on hand. Highly, if there's something higher than higher, that would be here. SVMC, that's misleading because they have a parent company that actually has more money. And Copley has a parent company with some more money as well. And so does UVMMC. But Springfield, NVRH, St. Johnsbury, Grace Cottage, Gifford, Brattleboro, and CVMC are all clearly in the vulnerable or highly vulnerable stage.
And this is current data.
This is for fiscal year 26.
Yeah.
And then you need a positive margin. You want a margin of 0 to 3%. Generally, that's how much money you're making off your operations. So think of the mechanic who has business every day, and at the end of the year, they lose 3%. That doesn't work. You can see here a number of Vermont hospitals, fiscal year 26, have actually negative margins. What happens then is it eats into the days cash on hand, and those reserves continue to go down. So when you see a steep operating margin loss of like 12%, that's huge. That's going to eat into a lot of your reserves and threaten insolvency. At these stages, something needs to give and needs to give pretty quickly and change quite rapidly.
Well, that's
Go for it. We'll just move over just a little bit.
so just 50,000 level again. We're gonna have less services and rates are probably gonna go up.
Correct.
Okay, just wanted to get that. And the rural health fund coming in, some of it, I just think I saw the slide you guys are gonna be using. And I'm just trying to figure out, is there a way that the hospitals can all agree on, 1 or 2 IT expansions, upgrades, updates, whatever, to make them look more affordable moving forward, make an investment they wouldn't normally make,
Yes.
but will make savings. And I don't know, I haven't talked to so I didn't know if that was something that you're hearing discussions about.
Yeah, great question. And lay back up to your first question, higher rates, fewer services. Yes. But also we want to see not like the services are gone, but they're transitioned to other places, increasing the access to urgent care, spending hours in urgent care. So maybe the service isn't at a quote hospital, but it's elsewhere, or they're consolidating their services with somebody else. Your second question, the Rural Health Fund, the application did include potential investment in IT infrastructure for hospitals. And there's a number of other strategies in there that get to this.
So,
Yeah.
but I want to go to the EMR, the
Right, that's
medical records,
exactly.
EHR. That is a huge part of what we did in 126 last year. So it had 3 components. That is one of them. And so the Rural Health Transformation Grant simply is an opportunity
That's right.
to help invest. Good.
See that we're at time. I want to be respectful of your schedules.
Take until 5 after that. Okay, all right, let's do it. We'll have you back. Though.
Kristen, if you want, just go to slide 21, please, Kristen. This is the rate increases on those plans I spoke about for fiscal year 26. So you can see Blue Cross had originally proposed an average of 13% for small group plans. The board approved 4. MVP requested 7 on average. We approved 2. And Chris, if you go to slide 21, or sorry, the slide before, individual plans, please. Yeah. Blue Cross requested a 23% increase. So the highest cost in the country, we need 23% more. That's big. And MVP proposed 7. The board approved 1.3% and 9.6. The point I want to make on this slide is that on the individual market, that's this market, the subsidies, a lot of Vermonters get subsidies from the federal government. Those have expired, which means the real pain is starting for families and people will be dropping insurance, which also hurts hospital finances if they don't have patients that are insured, patients delay care. It's not good. That makes it even more important to keep the rates as reasonable as possible, cognizant of all these other challenges. And I'll stop there unless there's questions.
So, yeah, so we're going to have you back in for a number of bills that we're working on, but also just for the more general conversation. But this is really helpful. And one of our, I think our mutual goal is to get to a place where we're lowering premium costs for patients. So making that connection between rates and premium costs, hospital expenditures. That's your job, but no, that's also our job in establishing policies that will help do that. We look forward to that work.
Thank you very much.
Thanks for having
Thank you very much.
Thank you.
Appreciate it. We'll have you back in.
18.5 hospitals per million nationwide.
18.5 per million.
Yeah, so we're,
For 14%.
yeah.
We're high.
Yeah.
Not a great.
But we're geographically dispersed, so we
Right.
go look at Wyoming or something.
Right.
Yeah.
like per square mile would be,
Yeah.
you know,
Right.
It's also what purposes,
Right.
how many of the services you're providing.
Yeah, that's a whole other.
well, I go look at.
Yeah.
Get